wire localization, how, when, and why.
مساء الخير. احنا دلوقتي هنتكلم عن ال wire localization. Localization was first described in 1966 in order to identify the location of an abnormality that may not be palpable. With an increasing number of non-palpable breast lesions detected due to improved screening, accurate localization of these lesions for surgery is crucial. Breast conservation therapy has become the preferred treatment for patients with early-stage breast cancer. In patients with non-palpable early-stage breast cancer eligible for breast conservation surgery, wire localization is widely accepted as a standard technique for preoperative image-guided lesion localization. More recently, new non-wire guided techniques have become available for preoperative localization. These include the use of radioactive iodine, electromagnetic radar reflectors, radio frequency identification, magnetic seed technology, and radio-guided occult lesion localization. So what are the steps of wire-guided localization? The first step is the selection of the guiding imaging modality. Then the equipment, the procedure, the aftercare, and the report. For selection of the guiding imaging modality, we have to check the lesion type. If it's a mass or an architectural distortion, then we're going to use ultrasound for guidance. However, if it's a focal asymmetry without ultrasound correlate, calcification, or clip, we're going to use mammography for guidance. If we have a mass with calcification, if the calcification is within the mass border, then we're going to use ultrasound. Yet, if the calcification extends beyond the mass border, then we're going to use the mammography. In enhancing lesions in contrast enhanced spectrum mammography not seen on mammography, we use contrast guided. The equipments we use are skin sterilizing agent, a local anesthetic, 5 to 10 millimeter syringe, and a localization needle with preloaded wire. Usually, the tip of the wire might vary in shape. It might be a hook or a pigtail. It's usually hidden within the localizing needle. It's only apparent after localizing the lesion. We push the wire tip to fix the lesion. However, we can see it before. The wire length depends on the location of the lesion, which helps best determine the approach and accordingly the wire length. The wire number depends on the lesion span, which is if less than 2 centimeters, and in single quadrant, we use a single wire. If more than 2 centimeters and multifocal, more than one lesion in the same quadrant, we use bracketing with multiple wires. The procedure itself, in mammography-guided procedure, a pre-procedural planning evaluating the target and the approach for the procedure. Whether we're going to use a craniocaudal or lateral view, whether we're going to use a lateral or vertical approach, this depends upon the location of the lesion. The most important thing about the wire localization is we want to reach the lesion through the shortest pathway to help the surgeon remove a small area of tissue, thus conserving most of the breast and having a better cosmetic outcome. So you have to choose which pathway leads you directly to the lesion in the shortest way. And if you can discuss with the surgeon which procedure he's gonna perform, you can facilitate this more. If the surgeon is gonna do a circumareolar incision, then the site of the entry of the wire is preferably close to the nipple and the areolar region. Usually in lesions in the upper quadrants, we prefer the craniocaudal views with vertical approach, and in the lower quadrant lesions, we prefer the lateral approach. However, this depends on each case. We can use the alphanumeric grid, which is used in older machines, the stereotactic guidance, tomosynthesis guidance, or contrast guidance. We use the compression paddle with a window to generate the scout image. The area of the target should be placed within the window. so that we can visualize the lesion. Here it's a clip, and this is an alphanumeric grid scout showing the lesion. In cases of alphanumeric grid, we have to determine the point of entry through the intersection between the two axes. However, in stereotactic guidance, we take a zero angle image, then an image plus 15 and minus 15 to produce these images. Then we mark the area we want to reach, and the machine automatically measures the distance that we have to cross to reach the lesion. If this is the lesion, we sterilize, then in the alphanumeric grid determine the coordinates. We insert the needle localizer with the wire inside. Then we remove the needle localizer. Here, this is the pre-firing and the post-firing images. In readjustable wires, we can readjust the location if it's not correct, even after removing the needle wire or sheath and releasing the tip. However, in non-readjustable wires, if we do this, the tip can be broken within the breast. If we need just minimal adjustment, we can do it using the touch pad attached to the mammography machine. But to do this, you need to know the axis you're gonna move. If you're gonna move in the lateral or medial direction, this is the x-axis. If it's anteroposteriorly, this is the y-axis. And if it's in the depth, this is the z-axis. So to sum up, we place the breast in compression with target area in window, obtain scout image to confirm target is within the window, targeting, and cleanse the overlying skin and apply anesthesia, advance the needle through the lesion perpendicular to the skin, obtain orthogonal image and confirm the needle location before wire deployment, then obtain final orthogonal image after needle removal. Then after the surgery, we have to image the specimen to ensure the presence of the lesion and the wire. These are some cases from the National Screening Program in Egypt. In this case, the patient received neoadjuvant therapy with complete radiological response, so we wanted to localize the clip. Here, the clip is seen within the window. This is the pre-fire, the post-fire, and the final image. In this case, there was a group of microcalcification. Here, the microcalcification are seen within the window, and this is the post-firing image. In this case, there was a mass lesion with calcification extending beyond the margin of the lesion and clip inserted posteriorly at the posterior aspect of the lesion before therapy. So here we needed to do a bracketing technique to ensure complete removal of the whole lesion. In ultrasound-guided procedure, as most of my colleagues said, whenever you see the lesion by ultrasound, just do the intervention with ultrasound. It's very simple, very easy. We localize the lesion, insert the wire, transfix the lesion, then start removing the sheath. Here, like this, we insert the wire and start removing the sheath after transfixing. There are 3 important measurements that has to be done in ultrasound-guided wire localization. The first is from the site of the entry to the tip of the wire. The second is from the tip of the wire to the overlying skin. And the third is from the overlying skin to the site of the entry. Then we have to do a mammographic image to ensure the proper position of the wire and a post-specimen image. The aftercare is by using tight bandage, advised to limit the movement, and the record has to include the patient name, the date, the lesion description, site, and by RADS, the procedure done, the number of wires, site and direction of entry of each wire, distance traversed by the wire to reach the lesion, distance from the lesion to the skin above, distance from the site of the entry to the skin above the lesion. The advantage of wire-guided localization is it lies in its being a simple tool that requires low cost. It can be inserted into the breast using mammography, ultrasound, or MRI, and its limitation include that it needs to be performed on the day of the surgery, which can limit the flexibility in surgical scheduling. It can affect surgical planning and execution, which may cause difficulty in following the wire track or the wire exiting the breast at a distance from the lesion, which can lead to excessive excision of healthy tissue, thus affecting the cosmetic outcome. It's highly dependent on the experience of the radiologist. There is risk of wire migration, which is spontaneous or due to patient activity, which can lead to inaccurate localization and potentially the wire's complete loss. Patients' discomfort associated with having a wire protruding from the breast, especially with the use of more than 1 or 2 wires. Thank you.